All people with diabetes can get complications over time. However, these are usually much worse in patients who have poor sugar control and high blood pressure. Sugar is carried to every part of the body, dissolved in the blood. Having too much sugar causes damage to the blood vessels. This damage can be divided into two main types. When the damage is to the major arteries, it is called macrovascular damage. Macrovascular damage is usually caused by a buildup of fat in the lining of the blood vessel. These form plaques or small bumps in the wall of the blood vessel. The result is that these can reduce the flow of blood around the body. Anyone can get this kind of macrovascular damage. But if you have diabetes, you are at much greater risk. Sometimes plaques can also break off and block blood vessels. So people with diabetes have 3 to 5 times the risk of having a heart attack. This is when the blood vessels, which supply the heart and keep it pumping, get blocked, and so the heart becomes starved of oxygen. They also have 2 to 3 times the risk of having a stroke. This is when a blood vessel in the brain gets blocked or bursts and causes damage in the brain itself. There are other factors which can make the risk much worse. Diet and exercise are very important because being overweight, even without diabetes, greatly increases the risk of macrovascular damage. Having high cholesterol levels in the blood is another risk factor, which can be reduced by avoiding fatty foods.
Unfortunately, here we don't test for cholesterol, and we don't have drugs to treat high cholesterol, but we do know that about 20% of our diabetics have a high cholesterol value. So we advise everybody to try and cut the fat down in the diet. And it's not the best treatment, but it certainly is some contribution to that.
Another major risk factor is smoking. These can damage both the major arteries and small blood vessels all over the body. So diabetics should not smoke.
Fortunately, in our diabetic clinic, we don't have a lot of smokers. We have a few, probably less than 5%. And, I always tell them they're mad. If you're a diabetic and you smoke cigarettes, you are crazy because you are going to end up the one with the amputation, the one with the blindness.
The second category of damage is to the tiny blood vessels, which permeate the tissues of the body. As the blood is pumped around the body, it moves from the big arteries into smaller and smaller blood vessels to carry oxygen and sugar to individual cells everywhere. People with diabetes are also at much greater risk of these tiny blood vessels becoming damaged, leading to long-term complications. This kind of damage is known as microvascular damage. Microvascular damage tends to show first in the eyes, the nerves to the feet, and the kidneys. What happens is that the lining of the tiny blood vessels get coated by sugar, and this prevents the blood from flowing.
Problems with the eyes and problems with the feet, problems with the kidneys are long-term complications of diabetes, and they usually start to appear when people have had diabetes of perhaps 5 to 10 years duration. And what's happening inside is that if you've had a high blood glucose or you've had a poorly controlled blood pressure or both, the small blood vessels get damaged and the flow of blood is impaired, and you actually get ischemia, so loss of blood supply to the retina or to the kidneys or to the nerves to the feet.
Damage to the nerves, particularly those that allow us to feel in our feet, is called neuropathy. Diabetic neuropathy first leads to loss of feeling in the feet. These can cause many other complications, and in some people even lead to an amputation. Damage to the eyes is called diabetic retinopathy. If untreated, these can lead to blindness. Damage to the kidneys is called diabetic nephropathy. The kidneys are the organs that filter all the waste and toxins from the blood to expel them from the body. So, damaged kidneys can also cause fatal illness. So people with diabetes have 50 times the risk of having a leg amputated. They have 20 times increased risk of going blind. They have 25 times the risk of kidney failure. Once complications do develop, can they be treated? The answer is yes, they can, but only if they are dealt with before damage becomes permanent. One of the main difficulties is to recognize complications early, because usually there are no symptoms until it is too late. This is particularly true of the eyes and the kidneys. Someone with diabetes will have no symptoms, and then they will suddenly go blind because of a bleed in the retina of the eye. Likewise, they will not feel any pain when the damage is being done to the kidneys.
That's great. And again, just look straight at that red dot for me. That's good.
Fortunately, there are other ways of telling. There are simple blood and urine tests to check for kidney function. And a clinician can look into the eyes to tell if someone has retinopathy. And if there is a problem, treatment can be given to prevent further damage. The eyes can be treated with laser. So it is essential that all diabetic patients get regular screening for complications. If someone with diabetes has not had their eyes and kidneys checked, then they should ask for these to be done. It is a service that all hospitals should be able to provide. So, are complications inevitable, or are some people more at risk than others? Once again, the answer is that people with diabetes can do a great deal to help themselves avoid complications.
We know what are the risk factors for developing complications, and the big number 1 and number 2 are poor glucose control and poor blood pressure control. And half of our diabetics have high blood pressure, so it's relevant to about half our patients. And if you have poorly controlled glucose, poorly controlled blood pressure, your risk is very much higher. So if a patient wants to help themselves, they need to really work hard to bring their sugars down, and they need to really work hard to bring their blood pressures down. Now, as clinicians, we can assist them, we can prescribe, we can counsel, we can educate. But at the end of the day, the patients also have to address the problem. I always say to my patients, we're a team. We can do so much, but you are the other half of the equation, and you also need to take this seriously.
This is Rodney. He has been diabetic for 4 years. He has not noticed any problems at all with his eyes, but that does not mean there is nothing wrong. The inner part of the eye is supplied with sugar and oxygen by tiny blood vessels. The high sugar levels that Rodney has had in his blood from diabetes could well have started to damage these. This might not produce any symptoms at all. So, the only way for Rodney to know is by coming along to the clinic for screening.
In the case of retinopathy, early on you just start to get leakiness of the blood vessels and you can see hemorrhages and exudates inside the eye. Later on you get development of new vessels which are trying to improve the blood supply, which is lost. And new vessels are dangerous. They're flimsy little things that don't have much connective tissue around them, and they can bleed spontaneously. And if a new vessel bleeds, it bleeds into the vitreous of the eye. It's the jelly in the middle of the eyeball. And if you bleed into your vitreous humour, you go blind.
The eye test is very simple.
KDOVHR.
The first part is to read out letters from a screen. This is to check how good the eyesight is and document any deterioration over time. The second part of the test is for a clinician to look inside the eye. This is best done with a slit lamp. This is a machine which shines a light into the eye. Through the lens, the clinician can look right inside the eye, to the retina.
You press on the...
Before starting, the clinician puts drops into Rodney's eyes to dilate them.
And you ask the patient to close the eye at least for 3 to 5 minutes so that the drug goes into the eye.
This makes the pupil as large as possible, making it easier to see inside. It is also possible to take photographs of the retina. The test is not painful, although the bright light can be a little uncomfortable and the vision may be blurred for a short time afterwards. If no slit lamp is available, the same thing can be done with a more simple handheld ophthalmoscope. Inside the eye, the clinician is looking for any signs of damage to the blood vessels on the retina.
The retina is at the back of the eyeball. It is the part of the eye which converts light into signals or pictures which the brain can understand. It allows us to see the world around. This is what a healthy retina looks like. This is a retina in the first stage of retinopathy, when unhealthy blood vessels start to leak, impairing central vision. This is the second stage, with the growth of new, flimsy blood vessels. If these bleed, they can create scar tissue, which can cause irreversible blindness. This is a retina where bleeding has already occurred.
Okay, so good afternoon. I'm Philip Burgess. I'm one of the eye doctors. So today we're going to do some laser on the back of your left eye.
Fortunately, there is a treatment which is painless and in most cases effective. This involves mildly burning the back of the eye with a laser beam to stop the tiny blood vessels leaking or bursting. The only way to know who needs this treatment is to do a regular screening of all patients at risk.
We know that the prevalence of retinopathy among Malawian diabetics is about 30%. So if you walked into a typical diabetic clinic in any district hospital and you looked around that waiting room, 1 in 3 people sitting in that room would have retinopathy changes. And one of the things about retinopathy is it doesn't affect the eyesight until you get a big hemorrhage and lose the sight. So it's an asymptomatic condition, and the only way you will know which of your patients have it is when you look inside the eye with an ophthalmoscope or a slit lamp. So, I mean, the way to prevent blindness is by screening, finding your 30% and making sure that all of them get regular access to ophthalmology review, because these changes can be treated with the laser. And we have lasers in Blantyre. Patients can be treated. We have a big laser clinic running now at the Lions Hospital in Blantyre. And all our diabetics in the country should have access to that care to prevent blindness.
The reason we're doing the treatment is that you have some leakage from blood vessels at the back of the eye. Diabetes can cause two problems. The first is growth of new blood vessels at the back of the eye. You haven't got that. The second problem is leakage of fluid, and you get leakage from the blood vessels near the centre of the vision. And the treatment for that is we then apply some gentle laser burns to the areas that are leaking to try and stop that fluid accumulating at the back of the eye. Okay, so if you can just put your chin on.
This is Lita. Because she is diabetic, she has been having annual screening tests for her eyes. At the last test, the clinician noticed that she had some leakage starting in the left eye.
There we go. Great. Okay, so looking straight ahead. Again, just look straight at that red dot for me. That's good.
So now she has come along to have it treated with laser.
Now.
Once again, she has had drops in the eye to dilate the pupils.
Okay, so we'll start the treatment now.
The treatment only lasts for a couple of minutes. It is not at all painful. The only danger is if Lita moves her eye during the treatment. So she is asked to keep very still and keep looking at a small red light on the machine. Otherwise, the laser could damage the central part of the eye. The clinician fires the laser. After less than 2 minutes, the treatment is over.
Type of treatment once, and then we just have to see you again in another 2 months.
Retinopathy is progressive. Without treatment, it will lead to the eyesight deteriorating and eventually blindness. So, once someone gets eye problems, it is very important that they keep getting checkups to look for any further signs of problems. If needed, laser treatment can be repeated many times. This lady has been living with diabetes for 18 years. She was diagnosed with retinopathy a year ago. Since then, she has had laser treatment 8 times and now she's better than she did before.
Anafika ndi kutiyeza sana ngufikira kupanga leza. Anaona maso anga amene analili ndi anandifotokozera kuti tikupanga leza pachifukwa chokuti shuga yalowa mu maso mwanu mukuoneka zilonda koma zosadesa nkhawa. Ine ndikuona kupindula kwambiri, panopo ndikutha kuona patali, sindimatha kuona munthu patali, pokhapokha ndiyandikane nayo. Komanso ndinasiya kuimba ulo nyimbo yakuchalichi pepa ina iliyonse, sindimatha kuti ndiwerenge, sindimaona, koma lero ndikuona.
She is lucky. About a quarter of patients will get some improvement like this. The majority, about half, will not experience improvement, but their eyesight will remain the same. The laser will stop it getting worse. Another quarter would experience further deterioration despite the treatment. Another part of the body that gets easily damaged by diabetes is the kidneys. These are the filter of the body. The blood passes through them and the toxins and waste are filtered out into the urine to be expelled. This cleansing is done through millions of tiny blood vessels, which can get damaged because of too much sugar and fat in the blood. If the kidneys do not work, then the body has no way of cleansing the blood.
What happens with nephropathy? Again, it's damage to the tiny blood vessels. The kidney starts to lose its blood supply, and initially the basement membrane of the kidney, which is one of the filters, becomes leaky. So proteins from the blood start to leak into the urine. And the very first sign that we can detect as clinicians of nephropathy developing is the presence of proteinuria. And what we advocate for screening is that every diabetic once a year should have a urine dipstick test to look for proteinuria.
So it is very important to get a regular urine test to check for kidney damage. If nephropathy is diagnosed early, then there are treatments that can slow down the progression. The blood pressure needs to be pushed right down, ideally less than 125/75 millimeters of mercury. This is difficult to achieve, but really makes a difference. We should also make sure the treatment includes a drug from the class known as the ACE inhibitors, which are particularly good for kidneys with diabetic nephropathy. Good glucose control, lowering blood cholesterol and not smoking are also important. If nephropathy is left untreated, then eventually the kidneys will fail and the person will need dialysis, which is when they need to be put on an expensive machine every few days to artificially clean the blood.
As time goes on, like with most kidney diseases, the blood pressure goes up, and a lot of our diabetics have hypertension anyway. And the blood pressure gets increasingly difficult to control. Usually this evolves over the space of a few years. And eventually the kidneys actually start to fail properly and the creatinine will rise and the patient will end up needing dialysis or some sort of similar treatment.
With both nephropathy and retinopathy, prevention is much better than cure. So controlling the blood pressure and sugar level is key. But screening is also extremely important to find the patients who are starting to develop complications. And if they have damage in one area of the body, the likelihood is they will have damage in others as well.
Again, about 30% of our patients will have nephropathy, and it won't surprise you that if you have one microvascular complication, you probably will have another, because the damage to the blood vessels is throughout the body. So those with retinopathy are more likely to have nephropathy, those with nephropathy are more likely to have retinopathy, and so on, which is actually quite important if you're screening, because you may feel it's too much to screen every patient in the clinic. So you need to screen your high-risk patients first. And if you know somebody has nephropathy, then they should be the ones who go first in the queue to have an eye test.
It is not only those who have already developed one kind of complication who are at high risk. Others who need priority screening include those with poor glucose control, with hypertension, who have had diabetes for a long time, older patients, those who smoke, and those with HIV infection.
Both kidney and eye damage do not produce symptoms, so they require medical screening at a hospital or clinic to recognize them. The same is not true of the damage done to the feet from diabetes. Here, diabetic patients can do a great deal to help themselves.
Yeah.
The first signs of problems are usually a loss of sensation to the feet. This is caused by damage to the tiny blood vessels which feed the nerves going to the feet. This is called diabetic neuropathy.
In this case, the microangiopathy affects the nerves that bring sensation from the feet to the spine and then to the brain, so your feet become numb. And the risk of having a numb foot is that you'll injure it and you won't know about the wound and it'll become worse and it'll become infected and you won't feel any pain from it, so you won't react appropriately and have it dressed and take antibiotics and so on. So one of the problems with a diabetic foot is the presence of wounds and late presentation, late recognition of wounds. And then you've got a second problem, is that some diabetics also get poor blood supply to the feet, and we call that macroangiopathy, which is damage to large blood vessels. Now, if you have a poor blood supply as well as a wound, then healing is poor. And then a third problem is that sugar makes a wonderful culture environment for bacteria. So if your diabetes isn't well controlled, you've got sugary tissues, sugary blood, poor healing, and a wound that you're not aware of because you can't feel any pain from it. And it's a horrible thing to say, but several times I've had patients who've only known they've had a foot wound when they've smelt it, because it was the gangrene they could smell. They never felt any pain in that foot.
At the diabetes clinic at Queen Elizabeth Hospital in Blantyre, about half of patients have some degree of numbness in their feet. So we spend a great deal of time on education to look out for any problems. All diabetic patients should try to regularly inspect their feet themselves.
The key for foot care is prevention. So all diabetics, at the moment in our clinic at Queen's, about 50% of diabetics have numb feet. So we need to know who are our clients with numb feet, and they just have to be educated. They must wear sensibly fitting shoes, they mustn't walk barefoot, they mustn't sit with their feet too close to the fire. And we've had some horrible incidences of people burning their feet and not feeling that. They must take good care every day to wash and clean their feet, to keep the skin soft with oil and lubricant, not to cut corns or to cut off hard skin with a razor, because you can cut the skin and not feel any pain from that. So the key to foot care is education and prevention.
Good prevention takes time and daily attention. So too often problems get left too late, and it becomes much harder to deal with them. Lucy has come in with very serious wounds on her foot. These have been caused by small cuts becoming infected and then turning into abscesses, which then eat away the tissue of the foot. Antibiotics have only a limited effect now, because they also require good blood supply to reach the affected areas. Some of the tissues are dead. If untreated, this foot is unlikely to improve by itself and may end up having to be amputated. However, we do have ways to treat even a foot as badly injured as this. Lucy is booked in for an operation which will aim to try to help the foot to heal by cutting away the dead skin and tissue. This operation is called debridement. At Queen's, we have surgeons who have learned the best techniques for this kind of operation. They open up the abscesses. It looks drastic, but doing this will give the foot the opportunity to heal from the bottom up. Lucy has been given anesthetic, so she cannot feel any pain during the operation. In reality, in very few cases should feet get so bad that the only alternative is amputation.
If you have diabetes, your risk of having a limb amputated is about 50 times more than a non-diabetic patient. That's a terrible risk. And we can bring that down. At Queen's, we did, in 2010 and 2011, about 18 amputations a year on diabetic patients. In 2012, we had a visiting doctor for the UK who was with us for a year. And she was a foot specialist, and she ran a foot clinic at Queen's, and she saw all these patients with wounds. She built up a good education program. She did, and our amputations went from 18 to 5. During that whole year, we had 5 amputations. And I have no doubt that it's because she was doing the right things with our feet. And it makes me realise that we should be aiming for that every year, and we can do it if we have the expertise.
Before coming to Queen Elizabeth Hospital, Lucy was told that her foot would have to be amputated.
I was so worried, I was so unhappy, I couldn't even eat the food well, I was crying most of the time. But I almost gave up that, no, I think my leg then is going to be amputated. As they advised me, they said it should be amputated below the knee.
Two months after the operation, and Lucy's foot has healed extremely well. There are still some small abscesses which need attention, but she is starting to be able to put some weight on it again.
Now, when you look at my leg, compared to how it was, because I was being carried, using a wheelchair, using a support walking stick, but this time I'm able to walk.